In the past, we concentrated on the joints themselves, pathomechanically speaking. That's the zygapophyseal joint for the thoracic spine, zygapophyseal joint, costovertebral, costotransverse, costomanubrial, costochondral joints, and in the cervical spine, of course, it's also the ancovertebral joint. Now, though, we're going to speak about the dysfunction through the entire segment. This will be an anterior subluxation where the vertebra and its attached ribs will basically sublux forwards, and then the transverse subluxation that can also be modeled as a rotational subluxation, we'll talk about it a bit more, will either go laterally along with the ribs, or it will rotate along with its ribs. So these are a little different. This is most assuredly an exaggerated look at that anterior subluxation. So what you can see is that the superior vertebra of the segment actually moves forwards and rocks forward. So you can also model this as a bilateral flexion subluxation, but it actually isn't. You won't get that same end feel as if these joints were actually subluxed. It's the whole segment has gone forward, and we'll talk about identified in a second, but the end feel you get from this is not that sort of a jammed end feel that you would get with the articular issue. Not usually anyway. So let's have a look, see how it shows us during the biomechanical exam. Just a word though, these things can either be severely painful or completely asymptomatic and just stressing out something else. I have actually seen one of these in a cardiac unit where they thought the patient was having a heart problem, and they did all the EKGs and other tests and decided it wasn't, and that he had a back problems, and I got called up to the cardiac unit and manipulated, and he was fine afterwards. That's how painful it can be. Anyway, if we do a biomechanical on this, we'll find that the position test is negative. Because there's no rotation involved in this, and it's not an asymmetrical dysfunction with one side moving more than the other, there is no positional fault, so that the position test will be negative. The P-PIVM, you'll find a symmetrical extension loss here, but the end fields will be screwed up, as will the PAVM, and the end field will be sort of an indeterminate end field. PAs, depending on whether this is painful or not. If it's painful, then when you do a PA on the sublux vertebra, that will increase the pain substantially. If you do a PA on the inferior vertebra, it may be a little painful, but nowhere near as painful as when you're pushing onto the superior vertebra. If these aren't, and there may be spasm, if the pain is sufficiently high, then you may get spasm when you're pushing on the superior vertebra. If there is no pain, then what you're going to see is basically abnormal end fields. So when you push on the superior vertebra, it's going to certainly feel abnormal. It's going to feel sort of a soft, weird feeling. I can't classify it. It's just not normal, but it isn't any of the abnormal ones that you normally feel. And similarly, when you push on the bottom one, this may feel jammed. On the other end, it may feel stiffish. It's a composite movement. Again, it can be very strange. What happens is if you try to manipulate these in the normal way, you tend to spring off them. They tend not to manipulate very well at all. You bounce off of them. Everything about it is weird, but I think what you can say is the position test is negative. Pushing on the superior one will give you a different end field from pushing on the inferior one, and if it's painful, it can be very painful, and pushing on the superior one will increase the pain substantially. Pushing on the lower one may not increase the pain, or it may increase it marginally. This picture depicts a translational subluxation, and what you can see here that the whole segment is shifted left. Now as it's done that, it's side flex as well. It will rotate, and it can rotate in either direction, either to the same side it's going or to the opposite side, and that probably depends on exactly the dysfunction you're talking about, the actual details of the dysfunction or the forces generating it. So it can rotate in either way. You can't tell anything from the rotation as to which side it's translated. You have to test that specifically. On position testing, you're going to find it's rotated, and it'll be rotated in the same direction in flexion and extension. This doesn't change. This is why we can model it as a rotational subluxation. The pattern for this, though, is not the joint glide for either of the facets, but rather you're looking for translation gliding. And when you try to, in this case, when you try to translate it out of to the right, rather, when you try and translate to the right, it won't go. It's just hard as nails, and it's not going to move for you. So this is telling you that it's sublux to the left, but the rotation, the P-pivot on the rotation, will be hypomobile. The translation out of that, though, will be hypomobile as well. But the true pattern for this is the translation, if you like, the translational glide. Okay, for the anterior subluxation, you can just try a straight traction manipulation. Now, depending on where you are, as far as where in the spine, how high up in the thorax you are, then you're either going to lift it, stabilize below, and then lift the sublux vertebra, or you can stabilize the sublux vertebra and drop its inferior partner down. But that's a straight traction manipulation. You can then do a traction with a posterior thrust. So you're reaching around in front, they're sitting, you're reaching around, as you lift it up, you pull back through their elbows. So in that position, and you simply pull them up and back. So you've done a traction manipulation combined with a posterior thrust. It's stronger, but you don't use that first. Just try the straight traction manipulation first. For the translation of subluxation, working on this translational aspect of it, you can try just a straight lateral shift, sustained hold, the way you do it in the lumbar spine as Mackenzie uses it. So essentially you just maintain that, shift over and see if it will hold, and if it will correct and then hold. If so, that's the least forceful way of doing it. Otherwise, you could try a traction manipulation, again, much the same way you did for an anterior, although that can also be done in lying. And you can also apply traction with a lateral thrust manipulation. This has to be done in supine, and it's a very much stronger manipulation, to the point where I actually don't let anybody do this on the course, because if there is any sort of weakness there at all, you could easily finish one of these off. So it's a much stronger thrust. Now, if none of these are working, then you can model this as a rotational subluxation and see about manipulating to improve rotation. So this will be done in neutral flexion extension, and it would be done in much the same way as you do your ordinary thoracic manips, but you would aim for the rotation, and that's where the end field would be, is actually in the rotation. Leave that option till last, though, because it is rotation. If anything's going to create soreness, it will be rotational. So that's the identification and treatment of these subluxations. As I say, you do see them in the lumbar spine, less commonly than the thorax, and the equivalent of this in the cervical spine would almost certainly be the unconvertible joint problem, except that this is actually occurring at a single joint, so it's only by courtesy an equivalence. But this is easier to understand how you can get this, given the number of joints involved, rather than lumbar spine, where it's difficult to see how that subluxation is held, and I really still don't know. I haven't got a good explanation for it, but the facts speak for themselves. You find these, you do a traction manipulation, and it's better. So it's only a model, but it seems to work quite well. So there you go, segmental subluxations.